So, welcome, friends, colleagues. We have come for the second iteration of the role of reproductive immunology and immune modulation back again this Wednesday at 6 p.m., which is the Why, When, and How series presented by Bharat Serum and Vaccines through their Bridging Bharat campaign. I welcome one and all. So, we have the when immune modulation in RPL and RIF today. So first, I would like to introduce Dr. Mugdha Raut, who is a partner at Dr. Raut Center for Reproductive Immunology, Managing Director of Dr. Raut's Women Hospital in Bacola in Santa Cruz. She is on the Education Committee of American Society of Reproductive Immunology, member of the Journal Editorial Board of Journal of Evidence-Based Women's Health in Egypt, member of American and European Society of Reproductive Immunology, MOGS, FOXY, and FIGO, to name a few. She has received many awards, primarily the Times of India Healthcare Achievers Award in 2018 for the innovative work in reproductive immunology, and she has many publications to her name, currently working on a book on immunotherapy in repeated miscarriages and recurrent implantation failure, a new horizon with Springer Publications. I welcome Dr. Mugdha again, and a warm welcome to all the audience who is tuning in to this exciting program. Dr. Mugdha, I request you to kindly take it ahead.
Good evening, everyone. Welcome to the series of webinars on the role of immunomodulation in repeated pregnancy loss or in recurrent implantation failure. At the beginning, I would like to thank Science Integra, TOG, and Bharat Serum for organizing these webinars and taking this initiative on this unique series of webinars, which is for the first time an open webinar planned on the subject of immunology, immunomodulation, immunology or reproductive immunology. I welcome all the doctors who have joined the webinar, and especially a warm welcome to the doctors who have registered from out of India. Reproductive immunology is an important field in the field of immunology and also for us obstetricians, because this deals with specifically the immunology of pregnancy. Reproductive immunology plays a very important role in a healthy pregnancy and preventing obstetric complications like RPL, PIH, unexplained infertility, IVF failures, IUGR, and even implantation failures. Now, many times in our practice, we do come across a lot of patients who have these problems repeatedly. They have gone to many doctors, and again they have come back to us for an opinion, and we remain helpless. We try whatever possible again and we remain helpless. But is there a solution we can offer to these patients? And considering all the causes, do we ever think of an alloimmune rejection of the pregnancy? Alloimmune rejection of pregnancy has been researched, discussed for many years, and reproductive immunology remains in a slightly gray zone. As for any problem, if we don't take it head on, we just slip it under the carpet, we are never going to try to find a solution and give the patient a solution to the problem. So the aim of this webinar is to throw light on this complex subject. And that's why we have divided this webinar into 4 parts. On 29th July, we saw the why of immunomodulation. Today, Dr. Mohan will be discussing when of immunomodulation. The next series will be how, and the 4th part will be dealing with the controversies, the recent evidences, and the future of immunomodulation. A part of each of these webinars is case discussions. When we discussed about this webinar series with many doctors, we realized that some of them are very well versed in reproductive immunology and they have been using immunomodulatory treatments with successful results. Hence, we planned in these discussions webinars so that these doctors can share their cases and their experience for all of us to learn. These always are generally the cases which are termed as unexplained, either repeated pregnancy loss or repeated IVF failure. Now, these case discussions after Dr. Mohan's talk will throw light on solutions to these complex problems. Yeah, I would now like to start introduce Dr. Mohan Raut. Dr. Mohan Raut is a consultant obstetrician and gynecology. He is a partner in Dr. Raut's Center for Reproductive Immunology and a partner in Dr. Raut's Women's Hospital. He is also a trustee of Dr. Raut's Immunotherapy Foundation. In 1992, or rather our journey started in 1992, when Dr. Mohan Raut was involved in the international multicentric research trial in association with Oxford University on the role of active immunotherapy in repeated miscarriages. He had been involved in the active immunotherapy program or LIT therapy in Mumbai. He has also contributed a chapter in immunotherapy in repeated miscarriages, pregnancy at risk, current concept, published by Foxy. He has published many papers and spoken in many national and international conferences on the topic of immunotherapy in repeated miscarriages. He has started India's first immunotherapy center recognized by the Drug Controller of India, along with me, Dr. Mugdha Raut. Currently, we both are writing a book on immunotherapy in repeated miscarriages and implantation failures, A New Horizon, with the help of Springer Publication, Germany. So now, Dr. Mohan Raut, I hand over the screen to you.
Thank you, Dr. Mugdha, for your kind introduction. I am also thankful to Bharat Serum and Vaccines Limited and Science Integra for arranging these webinars and also giving me opportunity to speak on this. Friends, all of us are here to discuss and know more about the interesting subject of reproductive immunology. In the last webinar, which you must have seen and heard, Dr. Mugdha talked about the basics of reproductive immunology, why reproductive immunology should be considered in the treatment of repeated miscarriages and implantation failure. Today, we are going to go one step ahead. We are going to see today when immunomodulation can be used, which patients will be benefited by immunomodulation, and can we select couples for immunomodulatory treatment. So, let's begin with today's topic of when immunomodulation. Friends, as Dr. Mugdha told in the introduction, our association with reproductive immunology or immunotherapy has gone more than 28 years. When I was part of the double-blind study by Oxford, and then we continued this treatment in Mumbai, and we started our own center around 6.5 to 7 years back, where we started our own treatment as well as research center, and we have been regularly treating patients with repeated miscarriages or recurrent IVF failures with immunomodulatory treatment, including lymphocyte immunization therapy for patients across India and from out of India. So today, let us see when we will do immunomodulation. This is my favorite slide. I put this in my every presentation because in 2016, there was an interesting article in Forbes that there are 5 technologies that are going to disrupt the healthcare by 2020 and further. And my friends, immunotherapy or immunomodulation is one of them. So you are at the right place at the right time. So the scope of all these 4 webinars, as you are aware, why immunomodulation, when immunomodulation, how immunomodulation next Wednesday, and the Wednesday after that is the recent evidence and controversies related to immunomodulation. So let's see when immunomodulation. To go a few the basic things, go through basic things which all of us are aware that the recurrent miscarriage incidence is around 1 to 2% of all the population or all the women. So it is definitely a very high incidence, and at a given time, a lot of patients or couples are suffering with this problem of repeated miscarriages. Same thing is with recurrent implantation failures. So the biggest question which is faced by all of us is, when should we investigate patients with RPL and RIF? Whether it is after one miscarriage. Why do we think so? Because as we all know, the risk of miscarriages increase as the number of miscarriages increase. And with 5 miscarriages, it is as high as 77%. So if we see the causes of various causes of repeated miscarriages, or even to some extent implantation failure, many of them are similar. But the disturbing part is only in 50 to 60% of couples, all these investigations related to these known factors are normal, and they are called unexplained, and they are handed over to nature. So the question remains, when should we investigate patients with RPL or RIF? Sometimes this amuses me. When I discuss with my cardiologist friends, and when I ask them, what are the chances of second heart attack after first heart attack? They say, and the literature says, there is 20% chance of heart attack after one heart attack. So 80% people are going to be without any problem. So why investigate? Does that hold? I don't think. But things apart, we have to seriously think when we should investigate patients after one miscarriage, two miscarriages or more. 2 more slides I would like to share from the last presentation by Dr. Mugdha, because these are going to help us to understand the investigations better. And the first one is about T lymphocytes. These are the most important part of our immune system, the cell-mediated immunity. And as the slide shows, there are 2 types of T lymphocytes, CD8 plus and CD4 plus, or also called as T helper cells, which are the most important part in immune system. The T helper cells are of 4 types: Th1, Th2, Th17 and Treg cells. Now Th1, Th2 are the irreversibly converted cells. So they are, of course, Th1 is important as an inflammatory cell, which helps in protection from infection, while Th2 is an anti-inflammatory cell. But from the immune tolerance point of view, for the maintenance of pregnancy point of view, it is the Treg cells and Th17 cells which are important, and their balance is important. Because Th17 cells are pro-inflammatory, while Treg cells are anti-inflammatory, or they can produce tolerance to the external agent, or in our case it is pregnancy. And the most important thing about Treg cells is they are inducible. This can be induced, and Th17 cells can get converted into Treg cells in presence of appropriate environment, or we can convert Th17 cells into Treg cells by immunomodulatory treatment, as shown in the slide, immunomodulation on LIT, where increase in Treg cells will help in protection of pregnancy. So this is one slide, and this is the second one. What are the various mechanisms that are there which protect the embryo and lead to rejection of embryo? If you will see that there is an interaction between the trophoblast and decidua, that is one point. Then there are certain changes in the decidua, certain changes in the peripheral blood, which lead to changes in the Treg cells, which leads to an anti-inflammatory or Th2 type of response, which leads to certain cytokine release and blocking antibodies and protect the pregnancy. So at each level, if we do investigation, if we check, we'll get to know. And at the end of the presentation, you will correlate this slide to the last slide, where various investigations are done at various levels in this diagram, and how we can come to know or predict or select couples who will be benefited by immunomodulation. So coming to when immunomodulation, the most important part here is to diagnose the alloimmune factor, and that is the clinical evaluation and the lab evaluation. I am not going into the details of clinical or certain type of lab investigations, but to complete the list, yes, the most important part is the obstetric history, which all of us are aware, the number of miscarriages, their dates, duration of pregnancy, spontaneous or induced, whether cardiac activity was seen or not, evidence of subchorionic bleed, presence of missed abortion, whether DNC was done, investigation during pregnancy, karyotype of POC is very important because that will tell us whether the pregnancy was abnormal or it was normal. Other related history, I am not going into the details, the clinical examination, investigations. Now, investigations are divided into two parts, level 1 and level 2. Level 1 are the tests which are done for factors which are known to us or for known factors which, as I have said, contribute 50% of or even less of all the causes. So these tests, I am not going into the details, the test for genetic factor, for POC, karyotype, pre-implantation genetic diagnosis, anatomical factor, endocrine factor, test of infection, test of autoimmunity, and all the tests related to thrombophilia. Why I have enumerated all these investigations is these are the tests which we are doing for cases which constitute less than 50% of the patients who are suffering from repeated miscarriages or recurrent implantation failure. The big chunk of 60% patients are not, or they are normal with respect to these investigations. So can anything be done for it? And that is the level 2 investigations. Level 2 investigations are certain specialized immunological investigations which help us to assess the immune system at various levels, at the cellular level, at the cytokine level, at the genetic level, and come to a diagnosis or conclusion which will help in the treatment of these unfortunate patients. The list, as you can see on the screen, includes lymphocyte cross-match, that is estimation of antipaternal cytotoxic antibodies or lymphocyte antibody detection, peripheral NK cells with a complete assay or NK cell inhibition panel, uterine NK cell estimation, estimation of a Th1 type of cytokine called TNF alpha, HLA-DQ alpha genotype of both the partners, T regulatory cell or Treg cell estimation, Th1, Th2 intracellular cytokine ratio, and KIR genotyping. This is a list, some of the tests which can be useful for the alloimmune problem detection, but of which still the first 4 are the most practical and easily available, maybe available in our country. We will see all these tests one by one and their significance. Coming to the lymphocyte cross-match. This was the first test which was used to select couples for immunomodulation. 28 years back when we had the research project, it involved this test. After that, when we started doing immunomodulation, this was the only test which we took help of to select couples for immunomodulation. So basically this is, lymphocyte antibody detection test. Lymphocyte antibody detection is a comprehensive test which, as I said, which helps us to select the couples, and it measures the amount of antibody that reacts with the protein of non-self, that is either paternal or donor lymphocytes. The method, there are various methods by which lymphocyte cross-match is done. This is an important test before transplant. So it can be done either by serology, by flow cytometry, or by even virtual cross-match on Luminex. But for our purpose, it is only the CDC cross-match which is sufficient, and the results are something like this. There is a cross-match between patient's serum and husband's lymphocytes, and whether it is positive or negative is seen at various dilutions of serum. And the interpretation is something like this, where the number of percentage of dead lymphocytes are seen, and accordingly scoring system is given from 1+ to 8+. And patients who have, say, less than 50%, or if you can say from this diagram, this chart table, anything which is weakly positive or less are definitely benefited by immunomodulation. And if they are positive or strongly positive by CDC, then it can be rechecked on Luminex to confirm whether it is really an antipaternal antibody or any other antibodies which are cross-reacting, to select to confirm that the patient will be benefited by immunomodulation. The importance of this test is that a negative cross-match test, as I said, in presence of unexplained RPL or in presence of unexplained recurrent implantation failure, indicates an alloimmune problem, and that immunomodulation will be beneficial in such a case. Here I would like to mention one small note, that if you do cross-match of all the couples who have had successful pregnancies, it is not necessary that all of them will be positive. But If the couple has repeated miscarriages, recurrent implantation failures, and still the cross match is negative, then she will be benefited by immunomodulation. It has been shown that odds ratio for live births was 4 times greater in women who were lymphocyte cross-match negative and were given immunotherapy than the control group. So yes, studies have also proven beyond doubt the importance of lymphocyte cross-match. The next test is natural killer cells in the peripheral blood. Peripheral natural killer cells are a part of innate immunity and they are responsible for immune surveillance. So they don't require activation, they are already there and they act on the cells which are not allorecognized. All foreign cells, the first thing is natural killer cells will attack them. There are in human natural killer cells, there are 2 types. CD50, these are the markers, CD56 plus, CD16 plus or CD56 plus, CD16 minus. In general, CD56 plus are again divided into bright and dim. The CD56 bright are present in the peripheral blood mainly, while CD56 dim are present in the endometrial lining. Now, how are these tests done? Either you estimate the proportion or percentage of these natural killer cells in the peripheral blood, or you check their inhibition, check their activity by inhibition panel or by doing a target cell test. The proportion of NK cells varies. There is a big range. The CD3 type of cells, the normal range is 60 to 85. Anything on more than that is significant. CD9, the CD16, 56 is more significant. And it has been found out that CD56 levels which are low, that is because here we have not, in India, we are not able to distinguish between the dim and the bright on a regular basis. So if CD56 is very low, then that is also a significant finding to consider patient for immunomodulation. NK cell inhibition panel, here intravenous immunoglobulin and intralipids are used and inhibition of NK cell is tested at various dilutions and accordingly we come to know whether this NK cell activity is high or not. And third is a test called K562 target cell test for NK cell activity, and it allows the quantitative determination of the cytotoxic activity of human natural killer cells. And the target cells are used and the percentage of target cells killed by NK cells is the measure of activity of natural killer cells. So basically these tests will help us to know the natural killer cell activity. What is the importance? Yes, increased concentration or proportion of NK cells and abnormal NK cell inhibition assay indicates presence of alloimmune factor, and these cases will benefit from immunomodulation or immunotherapy. Even a huge meta-analysis of 22 studies by Srividya Seshadri and Seshkamal Shankara in 2014 have proved that increased peripheral NK cell number is there in unexplained infertility and recurrent miscarriage patients, and increased peripheral NK cell percentage also is seen in recurrent miscarriage patients. The next is the endometrial NK cell activity, a very important test which we use regularly in our practice. Natural killer cells in the uterine lining, they play a very important role in the implantation and maintenance of early pregnancy. As you must have read that certain amount of natural killer cell activity at the time of implantation is is essential for proper implantation and formation of the vasculature, which is required for implantation of the embryo. So excess concentration activity of uterine NK cells has been shown to be associated with recurrent miscarriages or implantation failures. CD56 dim cells, which I said are predominantly present in the uterine lining, they can get converted into a cell called CD57 cell. So these CD57 cells are highly cytotoxic and they are detrimental to pregnancy. So if CD57 cells are found in the endometrial lining, then that's not a good thing. So we can test this for these cells by endometrial biopsy. And a simple endometrial biopsy between 19th to 23rd day of the cycle is done, and if the endometrium is collected in formalin and sent for immunohistochemistry, presence of CD57 cells is indicative of immunological problem, and patients require immunomodulatory treatment, without which they land up with either implantation failure or they have very stormy pregnancy, miscarriages, or early onset pregnancy-induced hypertension. So uterine NK cell estimation is highly specialized investigation, and of course the important part is a dedicated and interested pathologist is required for accurate results. Also, if it is possible, daily reference ranges for a given population are required to be prepared, and if that is available, then it will still help in better interpretation of these results. The next one is a cytokine estimation, serum TNF alpha. All of you are aware that TNF alpha is an inflammatory cytokine which is present in many medical disorders, including rheumatoid arthritis. So it is involved in systemic inflammation. It plays a very important role in maintenance of pregnancy and alloimmune rejection of pregnancy, leading to implantation failure or recurrent miscarriages. The increased production of TNF alpha during pregnancy has always been linked with recurrent pregnancy loss, recurrent implantation failure, pregnancy-induced hypertension, and even gestational diabetes mellitus. So uterine NK cells also produce TNF alpha, and it plays an important role in inducing miscarriage and poor pregnancy outcome. So the normal levels are 4 to 12 picogram per ml, and high levels are detrimental to pregnancy. In women who have multiple IVF failures, failed IVFs, TNF alpha is invariably high, and it is secreted in high amounts, and it inhibits implantation or early formation of placenta. So raised levels of TNF alpha with history of unexplained recurrent miscarriage or recurrent implantation failure indicate alloimmune problem, and immunomodulatory treatment, including lymphocyte therapy, will be beneficial. The studies conducted by Daher and Kim showed that a significant high level of TNF alpha was seen in patients with recurrent pregnancy loss. So levels of TNF alpha must be brought to normal before planning pregnancy or IVF cycle. Now we come to the next investigation is the HLA-DQ alpha genotype. It's the HLA estimation of the partners. HLA-DQ alpha genotype is a DNA test that determines the HLA typing. Now, you are aware that white blood cells have class 2 HLA antigens on their surface, and there are two types, HLA-DR and HLA-DQ. And each one is of two types, alpha and beta. So it has been found that mothers who have HLA-DQ alpha or beta, which is compatible with the fetus, that is, if the sharing with the father is to a greater extent, then there is increased risk of miscarriage before 8 weeks of pregnancy. It is very interesting to know how this happens. If a couple shares HLA-DQ alpha loci, then they have identical protein sequences on the surface. So the resulting embryo also has identical protein sequence. So due to this, the mother's immune system thinks that the embryo is a growth that is part of her, because the sequence is the same. It's part of her, but it should not, it's there where it should not be, and it treats it as a tumor, and the natural killer cells are activated, and they give rise to destruction of pregnancy and miscarriage. So therefore, this can be an underlying factor in certain patients, the HLA alpha sharing. T-Rex cell estimation. You saw in the initial slide that T-Rex cells play a very important role in maintenance of pregnancy. They have the tolerance, induced tolerance for pregnancy. So they are a subset of T lymphocytes, and they have potent suppressive activity. A good levels of T-Rex cells are absolutely important for continuation of pregnancy. So also prevention of certain autoimmune diseases. So they are important for reproductive immune tolerance to allow embryos to get implanted. So the normal levels of T-Rex cells are around 1 to 2% of the T cells, but anything less than 0.7 is a significant thing. This is a very important investigation, though currently not available here in our country, but abroad they use it as a regular method for prognosis of the pregnancy, and a falling T-Rex cell level is an indication of failing pregnancy, and the indication to start immunomodulatory treatment when the T-Rex cells fall. The next one is a Th1, Th2 cytokine assay and ratio. This is a test to determine the balance between the Th1, that is the pro-inflammatory, and the Th2, anti-inflammatory immune responses, and its role in repeated miscarriages. All of you are aware that Th1 cells produce certain inflammatory cytokines like interferon gamma, interleukin 1, TNF alpha, beta, leading to inflammatory response, and Th2 cells produce anti-inflammatory cytokines like IL-4, 5, 6, 10, so which protect the pregnancy. So by luminous processing, we can do this Th1, Th2 cytokine assay, and if T helper cells, if it indicates that there is Th one predominance, then that is an indication that the pregnancy is in jeopardy or the cause is immunological. The Th2 Th1 cytokine ratios are also studied with respect to TNF alpha to IL-10 or interferon gamma to IL-10, and a high ratio is indicative of an inflammatory response and an immunological cause. So, and the patient will be benefited by immunomodulation. The last of this investigation is KIR genotyping. The functional activity of natural killer cells is regulated by certain receptors on their surface. They are called killer cell immunoglobulin-like receptors or KIR receptors, and they interact with the HLA1, class 1 HLA of the embryo. So natural killer cells contain more than one type of KIRs. The KIRs of two types, the inhibitory ones and the activating ones. And KIR should either activate NK cells or inhibit them to produce soluble factors which are necessary for maintenance of pregnancy. So they are considered, KIR genes or receptors are considered to play an important role in maintenance of pregnancy. And this can be estimated by a simple, by a test through multiplex PCR test, and the DNA is extracted from the cell and is typed for KIR genes, and estimation of the predominant KIR inhibitory or inflammatory KIR genes are present. Accordingly, patients can be selected for immunomodulatory treatment. So these are the most important investigations. So coming back to the first slide, which I told you, the various mechanisms that lead to destruction of embryo. If you see in the slide and the investigations that we did, the lymphocyte cross-match will help us to detect whether there are blocking antibodies, also called as asymmetric antibodies or anti-paternal antibodies at the lower side. Between because of allorecognition, there are changes in decidua, which can be found out by estimation of endometrial NK cells. Changes in the peripheral blood can be found out by estimation of peripheral NK cells. Changes in the Treg cell or Th17 cells can be found out by Treg cell estimation. Th1 is whether the response is Th1 or Th2 can be found out by Th1-Th2 ratio. Whether which cytokine is high can be found out by estimation of TNF alpha. So if you see all these levels, at each level, one investigation is applicable, and that will help us to select couples. So it is not necessary that all the tests are required at a given patient or for diagnosis of alloimmune factor, but usually we do 3 or 4 tests, and these help us to select couples who will be benefited by immunomodulatory treatment. Now the next question is, are these tests really helpful? Is there any evidence-based proof? So there is an evidence-based update by Alejandro Kaminsbu in 2016, and which showed that these tests like peripheral NK cells, uterine NK cells, so they are not the evidence grade is not great or strength of recommendation is not great, but still they have recommended as evidence grade 3 and strength of recommendation C, which means that it's equivalent to a non-experimental descriptive studies such as comparative, correlation or case control studies. And the level C is based on category 3 evidence or extrapolated to category 1 or 2 evidence. The next thing that we usually hear is, should we do all the tests, all these tests? Because there are too many tests. Their sensitivity, specificity is different. They are expensive. But again, coming to the causes of recurrent implantation failure or recurrent pregnancy loss, as I mentioned in the beginning, all the tests initial which we do are for those 40 to 50% of patients. What about the remaining 50% patients? If we find out the underlying cause, which can be immunological alloimmune problem, then it is justified in doing all these tests. For example, the genetic factor is just 2 to 5% of all repeated pregnancy losses. The investigations that we do for it or the expenses for that, the money that we spend is really huge. Similarly, thrombophilia constitutes 8 to 10% of patients, but still there is a battery of investigations which are quite expensive. So I think we should open our mind and think with open mind about the tests which are required for each patient and each couple. We should think about it in differently. So different causative. Another thing which I want to insist is the different causative factors for recurrent miscarriages or recurrent implantation failures can coexist. Someone who has a alloimmune problem can have autoimmune problem, can have thrombophilia. So therefore, it is very important to have a complete workup so that there are less chances of failure, or there are less chances of us labeling these couples as unexplained or unexplained recurrent implantation failure or miscarriages. So before I end, I would like to mention this fact from Dr. Caroline Coulomb, that as much as 40% of unexplained infertility may be the result of immune problem, as many as 80% of unexplained pregnancy loss. So the number is huge, and it is our responsibility to do our best to help these couples by whatever way we can. And I would like to end with a quote from Albert Einstein: condemnation without investigation is the height of ignorance. Thank you.
Thank you, Dr. Mohan Raut, for the wonderful presentation. Now it gives me great pleasure to introduce Dr. Ranjit Joshi, who has done his MBBS and MRCOG. He's a very famous practicing IVF consultant in Nashik. And as I told you in the first part, that when we were meeting doctors for this webinar, we found out that Dr. Ranjit Joshi is extremely well versed in reproductive immunology and is very interested in research and doing new therapies to give success to his patients. He did his MBBS in India and then went to UK for further studies. He did his MRCOG in London. He trained for his super specialty in the field of IVF and reproductive medicine at St. James University, Leeds. Today we will be discussing a few cases which we have done together for active immunotherapy and why he considered them referring to us. The second speaker Dr. Ranjit Joshi, we'll start with your case. Now, the first case is a case of a 38-year-old patient, married since 14 years. She had a history of 6 repeated pregnancy losses. The first pregnancy resulted in a missed abortion of 8 weeks, which was a spontaneous conception. The second pregnancy also was a spontaneous conception, and patient had an IUFD at 30 weeks. The third pregnancy was again a missed abortion at 8 weeks from IVF pregnancy. Fourth pregnancy went up to 12 weeks through IVF conception and resulted in missed abortion. The fifth pregnancy was again an IVF conception but had a missed abortion at 8 weeks. And the sixth pregnancy, it was a missed abortion and it was again an IVF pregnancy at 8 weeks. This patient was on hypothyroid treatment, and also the patient had a cervical incompetence, which Dr. Ranjit Joshi will talk about how he handled this patient. Over to you, Dr. Ranjit Joshi.
Thank you very much, and very good evening to everybody. Thank you, Mugdha Madam, for a lovely introduction. And thank you for Bharat Serum to arrange such a nice academic, not so much talked about part of the IVF. But I hope that as the time goes on and there is more advances in awareness of immunology in pregnancy, we will get to know that everything will come down to immunology as a significant factor.
It is not seen on the screen.
Now, if we have to look at this case, obviously she came to me after the fourth miscarriage. So we did her IVF looking at the endometrial factor, because as there is immunological problem, there is also endometrial vascular problem in some of the cases, like how just Dr. Mohan has mentioned. So generally we do an endometrial Doppler in mid-luteal phase to see endometrial thickness and the blood flow by Applebaum score. So which was poor in her case. Her endometrium was about 8.5 and blood flow was up to zone 2. The experience is if we have endometrium which is around 10 millimeter or plus and blood flow of about zone 3 or more, they have a much better pregnancy, not only implantation, but a full-term pregnancy. We must remember that the placentation and the development of placenta happens in first 12 weeks. And once the full placenta is formed, that determines the placental reserve. So if we have a good placenta or good placentation in the first trimester and which has a good reserve, then this placenta has a capacity to give adequate blood supply to the fetus. Now, as the pregnancy progresses, we realize that the weight of the baby goes on. And as the weight of the baby increases, the calorie requirement or the blood supply requirement is also high. So if there is a placental insufficiency, the start of the placental insufficiency or beginning or the roots of the placental insufficiency in third trimester are actually in the first trimester. That how will the placentation happen? We have recently seen in last slides of Dr. Mohan that if there is inadequate if there is inadequate progesterone, if there is higher number of cytotoxins or cytokines, then there are lesser placentation. If it leads to a stage where the pregnancy cannot be sustained, that will lead to miscarriages. But between miscarriage and a normal pregnancy, there is inadequate placentation, and vascularity of the endometrium is another part. So this patient came after fourth miscarriage. Then we did her hysteroscopy and PRP and resection to increase the endometrial volume. That's one more area which we work quite a lot. We also inject PRP plus VEGF. She conceived the fifth time. Now, after fifth cycle, again she had a 7 weeks or 8 weeks miscarriage. And that time she was investigated immunologically, and yourself, Mugdha madam and Mohan sir guided us, and she underwent immunotherapy. After immunotherapy, she had another IVF cycle, conceived. That was a sixth pregnancy. The pregnancy went on well, and during second trimester, around 14-16 weeks, we thought that there is cervical incompetence on the sonography. So we took her up for cervical cerclage. And at the time of cervical cerclage, it was realized that there was probably an old healed tear, cervical tear, maybe during her IUFD, because retrospectively she remembered that she had blood transfusion at that time. That was the third pregnancy. And unfortunately, at 19-20 weeks, in spite of cervical stitch, she aborted. So then we turned out that if there is a cervical tear, we should go for laparoscopic cervical encerclage, which is theoretically the correct place to put in the cervical. So we did her laparoscopic cervical cerclage, then did the next cycle. She conceived. Then she had low molecular weight heparin throughout pregnancy. She had hydroxychloroquine as an immunosuppressant throughout the pregnancy. She went to full term at 37 weeks. She had spiked her blood pressure. Again, that tells us that if there is a poor placentation, Then she will have placental insufficiency in the third trimester. Then we sectioned her at 30. She delivered a baby girl of 3.4 kg, and she got discharged. They are basically from Andhra Pradesh, so they were here for a while, and 15 days ago they went back home to Andhra Pradesh. So now I think this is the clinical history. The point where what I would like to make here is the cytokines is a culprit, and fortunately due to corona, the cytokine and cytokine storm quite well in news at the moment. So what we can say that majority of the vasculitis, which is also happening in the COVID-19 cases, that the capillary endothelium is getting damaged, and that's why people who have pulmonary fibrosis, pulmonary insufficiency. So we have to kind of take that data or take that experience into the placental side as well. And I think that's where having the immunological status checked for a patient who have had miscarriages is most important. So we'll discuss the next case also.
Yeah. So the next case again, which we have done jointly with Dr. We have done many cases with Dr. Ranjit Joshi on active immunotherapy, and these are the 3 cases which he would like to discuss. This is a 38-year-old female who was married since 18 years. They had 4 pregnancy losses. They had history of 7 IVF cycles. First 3 IVF cycles had failed. Then in the next 4 cycles, the patient conceived. The first resulted in a missed abortion at 6 weeks. The second resulted in a missed abortion again at 6 weeks. The third pregnancy resulted in an IUFD at 16 weeks. And the fourth pregnancy resulted in a missed abortion of 6 weeks. Now, this patient also had a protein C deficiency. So, Dr. Ranjit Joshi, can you tell how you have handled this patient?
Yes, so I saw this patient when she came to me after 4th miscarriages. And then while investigating, I also investigated because she also gave a vague history of very deep vein thrombosis in her calf, which was, she didn't have much records, but that was what she could say in a layman's word. So I just connected the 2 dots, and then I thought that, okay, let me check her coagulation or hypercoagulable state. And there we found that she had protein C deficiency. So if we go to the next slide, then at the same time, because once you see a hypercoagulable stage, one can say, one is tempted to say, okay, we found the cause, we give her heparin right from the beginning till she delivers, and that will solve the problem. But considering the factors which were immunological, suggestive of immunological issues, so we did immunological investigation. We did lymphocyte cross match was negative, but when we discussed, then we decided to go for immunotherapy, which we did lymphocyte LIT, and then I did her IVF cycle. Now during IVF cycle, because hyperestrogenism is a prothrombotic stage, so such patients need to have anticoagulant, that is heparin, right from the start of ovarian stimulation, or whenever you start estrogen, say for frozen embryo cycles, you should start with heparin. That's one more point I wanted to bring out, that is not only to protect her from DVT, but also this low molecular weight heparin, particularly enoxaparin, because enoxaparin has been shown to have more activity or better anticoagulant activity than deltaparin and other compounds. So we did her IVF cycle, then she conceived and she did go to full term. Around 34 weeks of her pregnancy, there was IUGR. So that's where we started giving her intralipid. Normally, where we have or abdominal circumference is lagging by more than 10 days, that is asymmetrical IUGR, then once a week intralipid is given. In about 50 to 60% of cases, the intralipid reverses the oligohydramnias and the growth continues. So she went to 38 weeks. She had a section. She delivered, I don't remember because this was about 6 months ago, probably a baby girl. And we continued her heparin for 15 days postpartum. And then she was switched on to aspirin for rest of her life. And then she was discharged. So the intention of getting this case, or the message to do, is when I said that immunological investigation were suspected. Now, what do you mean? What do we mean by suspicion? I'm not really sure, but yourself or Mohan sir will say that immunological miscarriages are quite often very dramatic. That patient says it's like a host and graft rejection. So patient that she had little bleeding, little spotting. She went to the hospital and she bled profoundly, and everything came out as a flash. So Mohan sir, do you think you see more of these type of miscarriages?
Exactly. See, there are certain clinical presentations of these patients of recurrent miscarriage patients who have alloimmune problem as the underlying cause. Most of these have very high fertility. They conceive very fast. Maybe after one miscarriage, within 3 months, 2 months, 3 months, 4 months, they may conceive spontaneously. So that is one indication. And second thing is, as you mentioned, the presentation may vary from maybe just a little bit of spotting, but most of the times the blighted OVA, as we call it, the presentation without the fetal pool, is seen very commonly. Subchorionic bleeds is a very common presentation which is seen with alloimmune factors. So, and of course, the underlying factors, when we investigate and we come to know that nothing else is there, that also helps us to think in this direction. But as you say, these patients do have a dramatic presentation.
Because that was so I thought if we discuss that point, then it can be that if you have a dramatic patient comes in, bleeds, and it's like expelling out the graft. It's like a host and graft reaction, that there is sudden gush of blood and everything is out. So such presentations are more commonly seen rather than a missed miscarriage. Obviously, so I think that could be, though it is not very well studied, but we should be looking at when we document miscarriages, documented what type of miscarriage it is, that whether it was a miscarriage that nothing was seen and patient went for a routine sonography at 8 weeks and found that the baby stopped growth at 7 weeks, or whether that was a bleeding and then she miscarried and had a inevitable or incomplete or complete miscarriage. So I think having a note of these things will help us in future, that sometimes if it is a dramatic miscarriage, then it will be more likely to immunological, and then we can investigate these patients much earlier.
Yeah. So we'll come back to Dr. Ranjit Joshi again. I'll take the next case of Dr. Jagruti Ghosh. Can we have the introduction to Dr. Jagruti Ghosh? Can we have this with Dr. Jagruti Ghosh, the introduction of Dr. Jagruti Ghosh?
Dr. Mugdha, I request you to stop sharing your screen so that I can share my screen.
One minute. Yeah, can we have an introduction of Dr. Jagruti? Dr. Jagruti. Dr. Jagruti Nalaude Ghosh has done her MBBS and DNB in OBGYN. She is the director of Juana Mother and Childcare Hospital at Mira Road. She is a member of MOGS Youth Council for the third year, and she's a committee member of IMA Bhinder. So, Dr. Jagruti also is very interested in reproductive immunology and has treated a couple of cases of reproductive immunology. Dr. Jagruti, I'll just share your cases and then you can tell what treatment you did.
Okay.
Yeah, the first case of Dr. Jagruti is a patient of 17 miscarriages, 17 pregnancy failures, repeated pregnancy losses with 11 missed abortions. One pregnancy was a vaginal pregnancy at the age of 26. One first pregnancy went on to 26 weeks. It was a vaginal delivery, but baby died after 2 hours of delivery. Next was a second trimester abortion for a congenital anomaly, and then the patient had 5 spontaneous abortions. The patient was married for 9 years, had all documented abortions, and she came to Dr. Jagruti as she wanted to have a baby. Yeah, over to you, Dr. Jagruti.
Okay. Thank you so much, madam. I thank you, Bharat Serum and Dr. Mohan Raut and Mugdha Raut, madam, for inviting me for this webinar. So I have had some 2 cases wherein very interesting cases of recurrent pregnancy losses, out of which this is the first case where I heard of 17 miscarriages. So I'm sure all of you must be also hearing such cases very rarely. In this case, when she came to me, she has already had 17 miscarriages and all were documented. She had papers for it. And in fact, she, like Sir said, she would conceive very fast. Like when she was told not to conceive for 3 months after a particular miscarriage, even after her delivery, she was told not to conceive for 6 months. But still, she would conceive. Her UPT would come positive, and by the time she would go in for a sonography, she had aborted almost 5 pregnancies. So, urine, when she came to me, we did her routine test. All her blood tests were normal. A sonography, abdomen, pelvis was normal. HSG was done. Thyroid, all routine tests were done. Karyotyping of both the parents was done. Both the partners was done and was normal. HLA typing was advised, but she couldn't go for it. Thrombophilic profile was also advised, but for financial reasons, she did not do it. Now I started her on folic acid and multivitamins and started her husband on copropol and just sent her back. She came to me the very next month with a positive urine pregnancy test. What we did was I started her on a low dose aspirin, dydrogesterone twice a day, folic acid, multivitamins, and just followed her up. One thing which we did was we started her on intramuscular immunoglobulin. That was 16.5% every 21 days. With this, we did a sonography at 7 weeks, a dating scan, which was positive. Good fetal heart rate, everything was okay. A repeat scan was done at 9 weeks with a fear of missed abortion, so which also came normal. Everything was going well. Then an NT scan was done 12.12 weeks, wherein the NT was normal, but the dual marker was high. So the patient refused further tests, and in karyotyping she refused, and even in IPT she said no. She said, I'll accept the baby, however, whatever it is. So we started her on iron calcium, then did an anomaly scan at 18.5 weeks. The anomaly scan was perfectly normal, except that the cervical length was 2 centimeters. So with this 2 centimeter cervix, I had to do a cervical encirclage, which was done vaginally. At 19 weeks, everything went on well. At 28 weeks, the growth scan, she developed PIH. We had to start her on labetalol twice a day. And then again, a growth scan was done at 34 weeks. Her aspirin was stopped at 34 weeks. We stopped her prolyton depot injections and also her immunoglobulin. After which we had advised planned cesarean section 37 weeks, but because of the lockdown in her own society, she came to me at 39 weeks, wherein we did an LSCS and a healthy baby girl was delivered, who is now, yesterday only, she is 3 months old and everything is normal with her.
Hello.
Hello. Yeah, thank you,
Yes,
Dr. Jagruti. Yeah, Dr. Mohan, you would like to say something?
Dr. Jagruti, now the patient came to you at 19 miscarriages. Do you think she definitely had immunological problem? If the immunological consideration was done, was a problem was considered beforehand, she would have
have had.
she would have avoided so many miscarriages. Do you think
True,
so?
sir. True, sir. I completely agree that if an immunological workup would have been done, or at least somebody would have thought about giving her immunoglobulins, definitely she would have been a better situation and she wouldn't be at this stage with 17 abortion.
So you have been using immunoglobulins for all patients who have repeated pregnancy loss or
Yes, sir.
uh,
For patients who have more than 3 pregnancy losses, I use immunoglobulin.
Dr. Ranjit Joshi, what is your view about immunoglobulins?
I think immunoglobulins is again going back to the B cell activity. We can say that's the function of B cells, that they produce. I mean, if we say that, okay, there are two cells which you have mentioned earlier, that Th1, Th2, which are helper and cytokine producing, and the B cells are the ones which produce, or B lymphocytes to be specific, are the ones which produce antibodies. So T lymphocytes are producing cytokines. Now, if you have more number of B cells, more number of antibodies, your cytokine load will come down. Here, doing immunoglobulin, what we are doing is IVIgG or intramuscular, whichever way we give immunoglobulin. So we are increasing the immunoglobulin titer in the blood, which will reduce the cytokine ratio, and that's how that will pregnancy or prevent miscarriages. I think that's the hypothesis. Nobody has really thought or given any mechanism of action that how immunoglobulins are working, but this is one way which I thought it to be working.
Right, Dr. Joshi.
What are your thoughts? I mean, how do you think immunoglobulin is the mode of action, if we have to discuss?
Yeah, basically, as it has been found out, see, immunoglobulins, when they were started, they were intramuscular, used as intramuscular immunoglobulins for infections, for treatment of polio and other infections. But afterwards, when intravenous immunoglobulin came, then they started using it again for infection. But certain patients related to reproductive immunology problems were also given intravenous immunoglobulins. Though it is associated with more side effects or the cost factor. So the intramuscular immunoglobulin, which was there before, becomes a very convenient to use and produces the similar effect, its action on the natural killer cell activity. It suppresses the natural killer cell activity so that the Th1 type of cytokines are reduced. So basically an anti-inflammatory action, not high enough to be given, say, in a severe infection, but yes, strong enough to give in a Th1 Th2 imbalance. That's what I feel.
So we'll go on to the next case of Dr. Jagruti Ghosh. She was a 34-year-old patient, a nulli gravida with 2 failed IVF cycles. She had 2 failed IUIs also. In the second IVF, she conceived, but second time she did IVF, she conceived, but she came with missed abortion. And then later a spontaneous conception for the second time. The first time was a missed abortion 6 months before this. This couple was married for 8 years. So Dr. Jagruti Ghosh, can you?
Yes. So this was another case wherein IVF was done through my colleague, and this patient did her IVF. When the 2 IVF failed, she was worked up thoroughly for all the other causes of or the other problems like HLA typing was done, the thrombophilic profile was done, but everything came out to be normal. And then she had this, then she had the missed abortion, and after which she conceived, and then till 3 months everything was okay, and then she was sent to me. They had already started her on enoxaparin injections because her ANA had come speckled positive. So she was on enoxaparin injections and aspirin 150 milligrams daily, progesterone, oral plus intramuscular, and immunoglobulins every 21 days, the IM immunoglobulin. So then we continued the treatment similarly. All the scans, the blood tests were done as a routine AMC, and she is now 28 weeks, and till now her color Doppler and things are all normal. She's doing fine. Baby is doing okay. Let's see what comes.
Dr. Ranjit Joshi, would you like to say anything about this case?
Yes, now here it is, we have anti-nuclear antibody positive, which is a pro-thrombotic condition, or which damages the especially the capillary or vascular endothelium, and that's how it will lead to intravascular thrombosis and infarction of the placenta. So going on with the enoxaparin injection, it will protect by its anticoagulant activity. Immunoglobulin, again, by reducing the cytokines and the inflammatory markers, it will also reduce the anti-nuclear antibody activity. And I think patient should be able to do well. We need to continue with enoxaparin as well as immunoglobulin. Now, from 28 weeks or 30 weeks onwards is a time when we may be able to see some signs of placental insufficiency.
Mm-hmm.
So I think regular ultrasound to check the symmetrical growth of the baby, because if IUGR happens, it will be asymptomatic. Abdominal circumference is the one which starts lagging initially. Then you have oligohydramnias, then you have Doppler changes, umbilical, and then the last is the MCA changes. We can also keep watch on the CP ratio. So I think, if we continue with this, patient should be doing well. Yeah.
Dr. Mohan Rao.
I would like to add something to this. When patients have these obstetric problems, miscarriages or implantation failures, and if any factor, that is the autoimmune or thrombophilia factor is present, still, as I mentioned in my talk, there can be associated alloimmune problem. And just even in presence of only alloimmune problem, use of heparin, low molecular heparin, is still indicated, because it has now been, the studies have shown that in patients who have alloimmune rejection because of the alloimmune problem and the Th1, Th2 imbalance, the cytokines, the inflammatory cytokines induce certain changes in the vasculature. It has been termed as cytokine-induced vascular autoamputation, which leads to formation of microthrombi and blocking the vascular circulation, leading to the problems in placenta. So not only thrombophilic conditions, but because of the alloimmune problems also, there are vascular accidents, and therefore use of heparin, even in absence of otherwise considered indication of thrombophilia, is recommended in patients who have repeated miscarriages, even if all thrombophilia related investigations are normal. And it has definitely helped these patients. And so these patients, usually we continue low molecular weight heparin and aspirin till the 34 to 36 weeks of pregnancy. And these helps to prevent the late pregnancy complications, as Dr. Ranjit Joshi said, which are associated with alloimmune problem, Treg cell dysfunction like pregnancy-induced hypertension or gestational diabetes mellitus.
We'll go to the third case of Dr. Jagruti. She was a 30-year-old patient married for 14 years, nulli gravida. She had primary infertility, a bicornuate uterus, 5 IUIs had failed, one missed abortion. In the IVF cycle, she conceived in the second cycle when immunoglobulins were given. She delivered a baby boy at 36 weeks by LSCS for oligohydramnios. Both mother and baby are doing well. Yes, Dr. Jagruti.
Yeah, so this patient had started with fertility treatment since 5 years, last 5 years. I forgot to mention there that she was hypothyroid and on 50 micrograms of thyronol. So then she had one IVF cycle which failed, after which they thought of giving her immunoglobulins. And then when the immunoglobulins were started, probably aspirin was given, or even in for IUI cycles, she was already on aspirin. And then when the immunoglobulins were started, that time she conceived in the second cycle. And then the immunoglobulins were continued till 36 weeks. And then because of oligohydramnios and little IUGR component, a cesarean was planned at 36 weeks after giving her betnesol. And a baby boy was delivered. And both of them are doing fine.
So, anyone would like to comment, Dr. Ranjit Joshi or Dr. Mohan Rao? Otherwise, we'll move on. Yeah.
I think basically this case highlights the use of immunoglobulins, and the underlying factor, though it has not been investigated, so it is difficult to comment. But yes, the immunoglobulins which were not used before, they have been used, and it is found to be useful. But I think certain in all our cases, we usually have the immunological test which help us further. But yes, definitely this has helped this patient with previous fertility problems. So yes, it's a significant finding in this case.
So we'll move on to the next case by, this is our case, which I will be discussing the history, and Dr. Mohan Raut will be telling how it was treated. This is a 46-year-old patient who was married for 6 years. Primary infertility, irregular cycles, AMH was 0.5. All other investigations were done. 3 IVF cycles were done, all OD cycles. The first cycle failed. The second cycle resulted in a missed abortion at 8 weeks. The third cycle resulted in biochemical pregnancy. Patient underwent all the immunological investigations. The lymphocyte crossmatch was negative and her TNF alpha was raised. Dr. Raut, Dr. Mohan Raut?
This patient was referred to us by another patient, and late marriage, undergone IVF 3 times, it failed, twice she conceived and failed. So in spite of donor egg, so we thought about immunological problem, explained to the patient and the doctor, and because we don't do IVF ourselves, these patients are referred to us for immunomodulatory treatment. So we did the immunological test, which included lymphocyte crossmatch, serum TNF alpha, and natural killer cells. And as shown in the slide, TNF alpha was raised. It was 26. The normal range is 4 to 12, and the crossmatch was negative. So we posted this patient for posted this patient for lymphocyte immunization therapy. The patient underwent therapy with husband's lymphocytes, and post that, because after LIT is given, after a gap of 4 weeks, we advise them to undergo further treatment. Patient was also started on hydroxychloroquine 400 milligrams OD. All patients who have raised TNF alpha are started with hydroxychloroquine, and which helps to bring back the TNF alpha to normal. We don't use anti-TNF alpha medications, specific anti-TNF alpha injections like Humira, which are injections, and they cause extensive immunosuppression. So we take use of hydroxychloroquine or other antioxidants. And then the patient underwent IVF cycle. She conceived in the first cycle, and I think around 15 days back, delivered healthy twins. So this case highlights the possibility of autoimmune problem even late in life, and without apparently everything else being normal, and the two losses, pregnancy losses and one IVF failure. So the possibility of autoimmune factor should be considered in such patients. So this is about it. Dr. Joshi, you want to comment anything on it? Okay.
Yeah, this one thing I would like to comment is that this patient had a OD cycle, and still she had an alloimmune cause. So it meant that even if she was using a donor egg, her body rejected the pregnancy even in spite of a donor egg. So this indicates the importance of LIT even if you're using a donor egg, a donor embryo. Dr. Joshi?
I think I was coming to the same point, but in another way. If you remember that when myself and Mohan sir, we were in Oxford about 4 years ago.
Yeah.
That's where Professor Gavin Sachs from Sydney, I think he produced his data. And in the evening, he said that, we started using it for now, along with recurrent implantation failure or recurrent pregnancy loss. We started using it for IVF as well, IVF failures. Then I asked him that if you're looking at IVF, you might be having some patients with azoospermia, and there you are using donor sperms. So his answer was yes. So even though the sperm are from the donor, but the husband's lymphocyte do still do the job. So I think the sum and substance of this is, if we are doing immunosuppression for the cytokine suppression, whether it may be through lymphocyte immunotherapy or through hydroxychloroquine or by giving immunoglobulins, maybe intravenously or intramuscularly, the underlying mechanism appears to be the same. We reduce the cytokine storm, and like how we now know from the COVID era that these cytokines will ultimately have the microvascular thrombosis, which will lead to the microvascular amputation, like how Dr. Raut Mohan sir has said. So giving low molecular weight heparin will block the pathway, because the end result or end pathway for all these pathologies is the same, and that's where the heparin will work. So even if we are not able to find out a reason, but if there is a history, it is worth starting these patients on heparin right from the beginning, as early as. In some cases, we start low molecular weight heparin right after embryo transfer and continue till the 36 weeks, because you want to prevent the placental thrombosis and placental insufficiency.
So we'll go on to the next case. She was a 32-year-old female, married for 7 years, with repeated pregnancy loss, 5 missed abortions in the first trimester. All investigations were normal. Karyotype of products of conception was done twice, which was normal. Patient was advised surrogacy. Patient underwent an immunological, in fact, this patient did not want to undergo surrogacy, so she was advised immunological investigations. Her lymphocyte cross-match was negative. Her CD3 cells were high. Dr. Mohan Raut?
A very interesting case. The patient came to us by online search and said that I have been asked to undergo surrogacy. Is there anything you can do? So I explained to him about the underlying possibilities in patients who have 5 miscarriages where everything else is normal, and possibility of autoimmune problem, and patient was ready to undergo the investigations. After doing investigations, the cross-match being negative and the CD3 was high, we explained to the patient, and patient was given lymphocyte immunization therapy. The details of this treatment, of course, we will discuss in our next webinar next Wednesday, where we will be discussing how immunomodulation. And this patient did well. Along with that, we always use other immunomodulatory medicines, as Dr. Ranjit Joshi had mentioned. We start these patients on intralipids and also immunoglobulins, intramuscular immunoglobulins from the time of their conception, and we continue till 34 to 36 weeks of pregnancy. Intralipids are till 20 weeks. It is very important, and even the progesterone to be continued till 24 to 24 weeks, especially the dydrogesterone, because the around 20 weeks there is a second wave of placentation, and if the pregnancy escapes the initial storm in the first trimester, the second manifestation starts around 20 weeks of pregnancy. If the placentation is defective, then this patient lands up with early onset preeclampsia, and it becomes very difficult to treat these patients. All of you will agree with me, with severe oligohydramnios and IUGR, and these patients don't cross beyond 6 months of pregnancy. So it is very important to treat these patients with immunomodulatory treatment, which includes, as I mentioned, intralipids. Even in first trimester of pregnancy, we use steroids in selected patients with multiple miscarriages, and that has definitely helped these patients in tiding over the problem of first trimester miscarriages.
Yeah, any Dr. Jagruti or Dr. Ranjit Joshi, any comments on? We will come back to another case, very interesting case of Dr. Ranjit Joshi. She was a 39-year-old female married for 10 years with primary infertility. She had 7 IVF failures and she had PCOS. All investigations were normal, but the IVF was done for obstructive azoospermia. The embryo quality was always good. But in spite of that, she had the IVF failures. Dr. Ranjit Joshi, can you please?
Yes, definitely. I think I remember this case because this was our first case when we met and we started working together with regards to the LIT. So I think this was in year 2016 probably, or fag end of 16. So this patient came to me with clear-cut polycystic ovary and obstructive azoospermia. So every time he had a surgical sperm extraction and had ICSI, good embryos. So she came to me with 5 IVF failures. So the 6th IVF which we did, she had good embryos. And then we thought that if everything is good, endometrium is good, endometrial thickness is good, it's better to go ahead with some immunological investigations. Then we did the immunological investigations where she was found to have very high levels of CD3, low levels of CD1656. And I remember her TNF alpha was somewhere in the tune of, sorry about my light, but I'm just trying to adjust. Yeah. Some level of TNF alpha was, I think, around 100, so which was very high. 0 to 7 or 0 to 12 is the limit. And then we did the immunotherapy. Then 1 month after immunotherapy, I repeated the TNF alpha, and the TNF alpha was less. And then we did her IVF PISA cycle, which was successful, and she conceived and delivered. So again, this shows that when everything is good, till that time we did immunological investigations, she was a patient of unexplained implantation. Because all parameters were looking good, all endometrial flow were looking good. So I think once we have these kind of patients, we should keep our eyes and ears open and probably do the investigations much earlier. Obviously now the time has moved on, so we are doing more number of cases at much earlier level than before. So that was the point I wanted to bring out with this case. And also this is the first case of immunotherapy which I've done.
Exactly, Dr. Ranjit Joshi. I remember the case, and I think the most important point here is to consider about or to think about alloimmune problem beforehand or well in advance before patient goes on miscarrying multiple times or even IVF failures. We have been very commonly now getting patients after 2 IVF failures and the immunological workup shows immunological problem, and they undergo immunomodulatory treatment and continue treatment during IVF cycle and subsequently during pregnancy. And this has helped them to overcome the problem of not only implantation failure, but associated repeated miscarriages also.
Any other discussion, Dr. Ranjit Joshi? Anything else comes to your mind?
Or we will start with the questions so that the discussion can go on. I'll take up the first question. The question is from Dr. Chandrika. I think she had sent this question last time also. The question is, what is the is there any immunologic cause for occurrence of ectopic pregnancies in infertile patients? I think there is no specific immunological factor which will predispose to ectopic pregnancies, because it may be, as we are aware, related to maybe the infective process in the tube. Dr. Ranjit Joshi, would you like to say anything about it?
Yeah, I think if we have to look at it in a very simple manner, ectopic tubal factor. So if we look at a tubal function, we can say tubal function is in two stages. First stage is that it has to provide a good biochemical milieu for the oocyte and the sperm to fertilize and form a good quality embryo. That is a culture thing. And second thing is the resultant embryo is a spherical structure. It's like a ball. It doesn't have its own transport like how the sperms have. Sperms have a tail, they transport themselves. Embryo doesn't. So it is the responsibility of the tube to transport the embryo into the uterine cavity. And that we all know that it is done by the cilias, because it is the ciliary columnar epithelium which the fallopian tube has. And if we have any inflammatory damage, maybe endometriosis, infective pathologies, so that will damage this cilias, and we may not be able to get the second part of the tubal job or tubal function done. So I don't think there is any immunological part to it, but certainly there is an infective part which can trigger to immunological side, because in infective cases you do get higher TNF alphas and inflammatory markers. So that way it can be linked, but primarily the damage is not immunological. Damage is inflammatory, which is because of infective or endometriosis. Yeah.
Dr. Mugdha, would you like to add about something, any immunological role of tube in the pregnancy?
Oh yeah, the tube, apart from what Dr. Ranjit Joshi said, it is the tubal cilia which is very important, but it is also known that if the fallopian tube does not produce the growth factor, then there is a higher chance of this pregnancy resulting in repeated implantation failure or repeated pregnancy loss. And the tube not producing the growth factor also could be an immunological cause.
I think if we look at the other extreme, like hydrosalpingosis.
Yeah.
So the way hydrosalpingosis work is there is a big infection or inflammation there, because all the exudate in the hydrosalpingosis is all inflamed. And we know when there is a higher levels of local or maybe systemic inflammatory cytokines flying in, like what happens in hydrosalpingosis, you have much lesser chance of implantation as well as more chance of miscarriages. So I think the same way, so we can say that hydrosalpingosis ultimate activity is immunological, but the reason for hydrosalpingosis may not be immunological.
Immunological, yes.
Okay. The next question is TPO compulsory for all the patients?
I would recommend that TPO should be really done in all patients of repeated pregnancy loss or IVF failures. It should be included as a part of the immunological investigations. Because it is known that the TPO, if the anti-TPO antibodies are raised, then the anti-thyroid antibodies are raised, then it can lead to a failure of pregnancy, and these need to be handled well.
Yes, and I think with the high TPO antibodies, you can also have a normal thyroid function.
Yes, yes.
Just means that some patients have higher antibodies, but they are yet to affect the thyroid gland or thyroid function to do the damage and reduce the thyroid and lead to the hypothyroidism. So even though patient has normal thyroid, blood implantation failure or pregnancy loss, TPO is good, and these patients do respond well if we supplement them with thyroid. So if they have normal thyroid, they can have 50 or even 100 microgram of thyroxine in spite of having a normal thyroid function, because higher thyroid supplementation will lead to suppression of TPO antibodies.
Okay, the next question is what are the options with failed LIT? I think we have an entire session next week on the therapy on LIT and other immunomodulatory treatments. So I think it will be apt to discuss with that, because there are LIT is an active immunomodulatory treatment, while there are other passive immunomodulatory treatments. If not combined with LIT, it decreases the efficacy of LIT or the subsequent effect of LIT. So a combination of LIT and other immunomodulatory medications gives the best result. The next question is RPL, 2 IVF failures, LIT and all other immunomodulators like Barglov, steroid, HCQS, intralipid, all given, done before second IVF. The second IVF also failed. Conceive after that naturally, again miscarried. What options next? So basically, a lot of immunomodulatory treatments are given, and hopefully all other tests are also normal.
I think if we can say that all the immunological factors have been taken, there are two things one can do. One can reassess the inflammatory markers, that is interleukin 6 and TNF alpha, because these are dynamic. If you have done some kind of treatment, doesn't mean that it is good for life. In most cases, it is good for life. They do have second natural pregnancy, but it may change. The second thing is we also need to look at endometrial factor, and the best way to do a mid-luteal endometrial blood flow to see whether the uterine vascularity is good or endometrial thickness is good. So these are the two things which come to my mind straight away in cases like this, that she conceives naturally on one hand, doesn't conceive on IVF side. So I think it is to do with the endometrial issue, either vascular or immunological.
The next question is how often should we test TNF alpha and NK cells in patients with history of recurrent implantation failures being given LIT treatment?
Actually, we never repeat the TNF alpha or NK cells after giving LIT. Once the TNF alpha, if it is high, we treat it at the time of LIT itself. We start the immunomodulatory treatment. That is, we give HCQS and other antioxidants. And we till now we have never repeated or raised TNF alpha or NK cells. Dr. Ranjit Joshi, what?
I think as we discussed the first case which we did, the PC obstructive azoospermia, that was the only time I just checked TNF alpha again after 1 month of immunotherapy, and which was low, and then we started with the cycle, and then she had a But I think if like the last case, Dr. Mohan has mentioned that we spoke the same thing, that it check the TNF or the interleukin again, especially the interleukin 6 again, if things are not working. So it may be that we might have to give a booster dose of immunotherapy.
Yes.
Repeat the immunotherapy maybe a couple of times more, because some patients may not get benefit from one session of lymphocyte LIT. So I think in such cases, yes, there is a scope for repeating it.
The next question is, on which day of menstruation should Bharglobe be given preconceptionally for thin endometrium?
Okay, if our intention of giving Bharglobe to improve the endometrial thickness, if that is the intention, then I think we have to question the intention. Is Bharglobe going to improve the endometrium? If there is immunological reason for thin endometrium, which is quite rare, then it will help. But in majority of the cases, what we see is the fibrosis or subendometrial fibrosis because of some endometrial damage. And this endometrial damage is mainly either infective, which is going on there for a long time, or surgical, if patient has had gone through curating or DNCs for miscarriages or diagnostic reasons, and then the endometrium thickness reduces or endometrium stops growing. So in those cases where there is subendometrial fibrosis, there is poor vascularity, probably Bharglobe will not help. But those cases who have immunological problem or raised inflammatory markers, which is inhibiting the angiogenesis, because we must remember TNF alpha is a receptor, polypeptide receptor inhibitor. So it will block many of the hormones, including FSH, LH. It also blocks insulin. That's why we see people who are diabetic and have in some kind of infection, their sugar level automatically went down. And that phenomena is transient, that phenomena is temporary, and that is because of TNF alpha. So TNF alpha is essentially a receptor blocker. So, thin endometrium, immunological reasons is very, very small number of cases. We should look at infective or the subendometrial fibrosis cases. Yeah.
Okay, thank you, Dr. Ranjit Joshi. The next question is, how do you do LIT? I think Dr. Shobha, you'll have to wait till the next Wednesday to get the details of that. We'll go to next question. If we have to do single immunological test, which test should be done? I suppose the question is related to the test for alloimmune problem, right? So, Dr. Ranjit Joshi or Dr. Mugdha?
Yeah, rather I would say HLA cross match and TNF alpha is a must. These are the two tests which are very important. Another important test which I would like to tell about here, which you mentioned in your talk, is the endometrial CD57, which is either done usually during the 19th to the 26th day of the cycle or on the first day of the period. The endometrial CD57 is an extremely sensitive test. So if you're going to do one single test, then please do an endometrial CD57, which can tell us a lot of things about it. Could be even meaning the TNF alpha is raised. Dr. Ranjit Joshi?
Yes, I think TNF alpha will be a good marker to see what the cytokine activity is going on. CD57 we can do. The peripheral blood NK cell, which is quite easily available with lab, and that will give us the percentage or absolute count of CD3, which are T cells, or CD16 B cells. So yeah, I think these two tests will be the first pick: NK, peripheral blood NK cell and TNF alpha.
Okay, thank you, Dr. Ranjit Joshi. The next question, I think Dr. Jagruti should be able to answer. Should we start immunoglobulin before starting pregnancy treatment? Dr. Jagruti?
I think once she's pregnant, then we should start the immunoglobulins.
And how frequently?
After confirming the pregnancy. Immunoglobulins, if you're giving intramuscular immunoglobulins, then every 21 days, because the half-life is 23 days. So you should give it every 21 days till 34 weeks.
And in an IVF cycle, or when say you're planning IUI, would you like to use it as an additional supplementary medication when you're planning IUI? Say around the IUI, or so will That's what the question wanted to know. I think doctor wants to know whether it can be used
With
before
IVF cycle after embryo transfer, we can start immunoglobulin immediate.
Okay. Anything to be added, Dr. Joshi?
I think for IVF cycle, in such cases, we can add low molecular weight heparin from embryo transfer, because if we have to prevent the thrombosis part or microangiopathies, pregnancy is actually a retrospective diagnosis, if we see. So when implantation happens, that time, if the anticoagulant is there, then that is the best part. So when we are doing embryo transfer, maybe day 2, 3 or whatever, we know the implantation is going to happen in 2 or 3 days or 4 days, depending on when we transfer the embryos. So it's better to give low molecular weight heparin from that time in such cases. But patients who are conceiving naturally, or when we are trying IUI where the chances of pregnancy are relatively much less, then it's better to start as soon as we diagnose the pregnancy.
Okay. Thank you, doctor. Which are the specific cases in which you give intralipid, and how do you give? I think we can briefly mention about this. The detail anyway we'll discuss next time. So
yeah. I think if we look at the intralipid, the original study which was done in Nottingham, they did the TH1 TH2 ratio, but I guess we are not able to do the TH1 TH2 ratio in our country. And let me know if we can do it now in Mumbai, Mohan sir. So in this Nottingham study, they took, I think, 74 patients who had 5 or 6 IVF failures with good endometrium, good embryos, and then they randomized half and half, 34 and 34, something like that, or 32 and 32. And then they gave intralipid once every 2 weeks. And where patients had intralipid, they had much better implantation rate. Now, if we have to look at intralipid, that again will tell us probably how intralipid works. Intralipid is a very old product, started in 1962 as essential fatty acids. And the initial purpose was to do TPN, total parental nutrition, for geriatric patients or oncology patients. So part of TPN. So intralipid essentially contains very large amount of MUFA and PUFA. That is monounsaturated fatty acids and polyunsaturated fatty acids. Now these MUFA and PUFA is a very good scavengers for the oxidative stress. So again, if we link these things, that the cytokines produce oxidative stress, intralipid will reduce the oxidative stress, and that's how the effects of the oxidative stress will be reduced. And I think one can say that whatever levels of TNF alpha or inflammatory markers are, if they are very high, then you can intralipid maybe once a week also.
that's true. Thanks, doctor, because I think intralipid has an action on the NK cell activity, suppressing the inflammatory response. How to give it, we will discuss next time. How do you administer VEGF? What are the specific indications? I think Dr. Ranjit Joshi, this is your special field, but if you can briefly just explain the use of VEGF. So because it goes into the therapy part, which we'll discuss next time. But anyway, you are expert with VEGF, so we'll want to know your view on this.
Okay, the VEGF is one of the 4 angiogenic growth factors. If we look at angiogenesis, then there are 4 angiogenic factors. One is PDGF, that is platelet-derived growth factor. VEGF, that is vascular endothelial growth factor. Then I think angiopoietin 1 and angiopoietin 2. So VEGF is part of the PRP. So when we are doing the platelet-rich plasma, these VEGF and PDGF granules are expressed on the surface of platelets, and that's why the PRP will help angiogenesis. Now, important thing is, when we are doing the PRP, what we have learned here, or which was published 2 years ago in a hematology journal, that if you centrifuge PRP and you inject it, then these platelets are involuted because of centrifugation. So they need to be agitated for some time, at least 4 to 6 hours. So what we are doing in Nasik is we have designed a special bag, non-human touch technique. These bags collect blood bank collects the centrifuge, and then we get the PRP, and then the PRPs or the platelets are agitated for overnight, and we get the platelets next day. So that way, it is proven by the flow cytometry that the platelet count is much better. Activated or agitated platelets are better. So essentially, VEGF is an angiogenic factor, and wherever we want angiogenesis, like say example, poor endometrial vascularity is there, then you can instill it, or you can do histoscopy and inject it into the subendometrial area. Injecting VEGF in some subendometrial area is much more effective than just instilling it into the uterine cavity, because angiogenesis need to happen in the subendometrial area. So that is true for the PRP as well. So I think wherever you need vascularity, you do that.
Okay, I think thank you very much. I think you will speak for hours on this subject, I know. But we go to the next question. What is the standard dose of low molecular weight heparin do you routinely use? Dr. Jagruti or sir?
If you look at the studies, the prophylactic dose is 0.75 milligram per kg body weight. So if we say like 50, 55, 60 is the average weight, which most women want their weight to be. So 40 milligram is a good dose, but if somebody is on a higher side, then we can go to 60 also. Jagruti, you want to?
Yes, sir.
Jagruti madam, you want to add?
Nothing, sir. Same thing. That if the patient is less than 60, then I prefer giving 0.4. And if the patient is more than 60, then I give 0.6.
Okay, thank you. The next question is LIT to be given when and the dose we will discuss next time. I think 33-year-old patient, para 1, living 1 with 4 miscarriages, all spontaneous conceptions. Alive female baby 6 years old, followed by 3 spontaneous abortions. So the question, what is the treatment? I think it's 4 spontaneous conceptions, spontaneous conception, 4 miscarriages. Dr. Mugdha, or what will you recommend?
This is just pardon my audio. We call it secondary aborters, and the secondary aborters also could be having an immunological cause, where I think the patient has to be investigated. In majority of these patients, we have seen that they had a difficult first pregnancy, and that results in subsequent second trimester loss, first trimester losses or abortions, and looks like an immunological cause which should be investigated.
Okay, thank you, Dr. Mugdha. When to give immunoglobulins in IVF cycle, that is FET?
Dr. Ranjit Joshi?
I think whether it is a frozen cycle or a fresh cycle, the immunological status or the endometrial status will remain the same. So when you are having a diagnosis that you need to give immunoglobulin, then it is better to start when you start building the endometrium. That is from the stimulation point. In frozen cycles, where you are inducing the endometrium or stimulating endometrium with estrogens, you can start with that. In a stimulated cycle or a fresh cycle, you are actually building endometrium from the day you start stimulation of with gonadotrophin. So you can start immunoglobulin from that stage. So I think if we have endometrium which is growing in presence of immunoglobulin right from the beginning, will function better than an endometrium which has grown without immunoglobulin, and then we add immunoglobulin at the time of embryo transfer.
Great. Thank you, Dr. Ranjit. The next question is, can you explain LIT in detail? Dr. Isha, I think please join on 5th August. We will have these discussions on 5th. The talk is there, and see you next time.
Sir,
the question is
today is 5th August.
Sorry, not the 5th, 12th August. Sorry. At 20, next question is at 20 weeks of pregnancy, proper placentation seen on Doppler, should we continue low molecular weight heparin?
I think if the patient has an immunological problem, it's better to continue low molecular weight heparin, because there is a second wave of placentation which is going to happen at 20 weeks. And if at that stage, even if the previous placentation is normal, the immune attack can happen again at 20 weeks. And that is why we need to continue it up to 24 weeks at least. Dr. Ranjit Joshi.
Yeah, I mean, it's I think one question which strikes to my mind, which I don't have much personal data. See, the way we are assessing the placentation or placental growth or development is by ultrasound. Now, ultrasound will only tell us the structure of the placenta, that how thick it is, where it is, what thickness it is. And what we are really interested in is the functionality of the placenta, whether it is giving adequate blood supply to the fetus. So, if we say that ultrasonic structural assessment of placenta is gonna give us good idea about functionality of the placenta, then we can say we can stop the heparin. But structural assessment of placenta is not gonna tell us about the functionality of the placenta. Then probably that investigation is not good enough for our purpose. And as you said, that immunology is a dynamic thing. Like we have seen, there are patients with primary immunological failure. There are patients with first normal deliveries and then immunological problems in subsequent pregnancies. So it is better to continue with low molecular weight heparin.
Okay, thank you, Dr. Ranjit. The next question is, what is the dose of hydroxychloroquine and how long it should be used? And similar question, when and how much dose should HCQS be started? And is it safe to be continued throughout pregnancy? How to choose patient for HCQS, on what history based in RPL? So basically the question is on hydroxychloroquine, its use in RPL, and how long it can be used, and is it safe, and when to start?
I think this will be covered in the next talk on the 12th of August. So that will have a detailed discussion.
Yeah, I think I will just briefly add, Dr. Ramya and Dr. Nahid, that hydroxychloroquine can be started even before planning pregnancy. You can start it by which investigation you have asked. See, if the TNF alpha is high, then definitely it's an indication. And many a times it has been found out that, as I always mention, that the autoimmune problem can coexist with alloimmune problem. And because whatever test which we do for autoimmune problem, or for that matter thrombophilia, everything is not included. Say for Apla syndrome, when we do test, we don't do for all antiphospholipid antibodies, phosphatidylserine and phosphatidylinositol. So there might be underlying autoimmune factors. So therefore, HCQS should be started before planning pregnancy, continued throughout the pregnancy till 36 weeks. All further details we'll discuss next time. So the next question is, sir, if patient's thyroid profile has become normal, no, I think it's not clear. Can you please enlighten us about immunological investigation at a glance, please? I think we had a talk today where we discussed about various investigations that can be used in to detect the alloimmune factor, and it is very difficult to go in the details. But yes, the important investigations, 4 investigations that which we do is lymphocyte cross-match between husband and wife, natural killer cells in the peripheral blood, endometrial natural killer cells, and estimation of serum TNF alpha. So these are 4 tests which can be used to help select a patient for immunomodulatory. Which lab is doing endometrial CD57? Which
we send it to Metropolis. Metropolis lab is doing it. Hello? Yeah, we send it to Metropolis labs.
Okay. So coming to the next question. Okay, I think we come to the end of the questions, and I think I would like to end the question and answer session here. And I think before handing over the mic to Mr. Sekhar Banerjee, I would like to remind all the viewers that we'll join again on 12th of August for the next webinar in this series on how immunomodulation in RIF and RPL, and we will be joined by doctors for the case discussions. So all of you are welcome to join for the next webinar. And over to Mr. Sekhar Banerjee.
Good evening. Good evening to all of you. First of all, I would like to thank those who are connected now, and you will be very happy to know that there are already 620 connections. Registrations had happened. So the last one, when there was another webinar, the last Wednesday we had done, there was also almost 600 registrations were there. And this time also 620. And what we expect that all these doctors, those who are registered today, will once again will be with us on the next Wednesday, that is 12th, and when how part will be discussed, and that will be the most interesting one. Thank you, Dr. Mohan Raut, Dr. Mugdha Raut, and Dr. Jagriti Ghosh, and Dr. Ranjit Joshi. Thanks all of you. It is a sort of what is the difference what I have noticed with the other webinars are happening. This is something that everyone is expressing or sharing their practical experience, and that is the most important one. It's not just a book theory. It is the practical experience which is being shared with all. I think that is most appreciated by most of the participants, most of the doctors who has registered are connected now. The Bridging Bharat initiative will continue to take place by Bharat Serums. Now it is reproductive immunology. It is going on. Another 2 we will be doing in this particular series, and then after we will plan even more. So till the time, I would like to thank all of you, and very, very good evening. So please be connected on 12th, the next Wednesday, for how part of reproductive immunology. Thank you. Thank you, Doc.
Thank you.
Thank you.
Okay.